Welcome to May's lunch break broadcast brought to you by the American Sleep and Breathing Academy, where we provide wonderful CECs and information to help advance our knowledge. This month we'll be covering BiLevel therapy and titration. This month's broadcast is going to be presented by Sarah Mahoney, MAHED, BSRT, RRT, RPGST, and RST. I hope you enjoy this broadcast, and please don't forget to sign up for all of our future webinars that we have coming up. We try to do these every month, and enjoy.
All right, so good afternoon, everybody. I'm Sarah Mahoney, and as Alex said, we were going to be talking about BiLevel therapy today. The objective for this webinar is going to be when and why BiLevel is used, the importance of the titration process, the difference of spontaneous mode and spontaneous time mode, the optimal pressures that's obtained, the importance of education and compliance. And at the end of this presentation, we will be allowing time for question and answers. So to get us started, we really need to know about what BiLevel is, taking it back to the basics. We have IPAP, which is our inspiratory airway pressure. We have EPAP, which is our expiratory airway pressure. The higher pressure is referred to as our inspiratory airway pressure, which is our IPAP. And the EPAP is our lower pressures. What EPAP does is it overcomes the physiological events trying to close the airway during the expiration phase of breathing. And our IPAP, it works at maintaining our airway patency during inspiration. There is a requirement minimum pressure difference of 4 centimeters water pressure and a maximum pressure difference of 10 centimeters water pressure for the ranges from IPAP to EPAP for the ASM guidelines. When and why BiLevel is used? BiLevel can be used for intolerance of CPAP therapy. One of the main uses for intolerance of BiLevel is this CPAP therapy intolerance. The patients who cannot tolerate CPAP pressures are able to tolerate it because BiLevel is able to decrease higher pressures from the CPAP. BiLevel allows patients to maintain airway stability with lower mean airway pressures as well. The nature of BiLevel allows patients to be more comfortable because of the changes in pressures create a natural breathing pattern. BiLevel also allows for decreased work in breathing that's used to overcome exhalation phase with CPAP with the drop in pressure, makes it much more comfortable. And during exhalation, the use of BiLevel maintains the airway integrity, avoiding any obstructive events during the inspiration with the increased pressures. CPAP intolerance. During the sleep study, you know when a patient is in need of BiLevel when you can see that they're having a difficult time tolerating CPAP. But they also may complain about pressure. They may be titrating at higher CPAP settings. They could have even increased sleep latency or time awake after arousal. Can all be related to CPAP intolerance. Patient complaints are one of the most important reasons for BiLevel treatment. Patient compliance is a critical aspect in any medical treatment, just like it is in any other discipline as it would be for polysomnography. When a patient is making complaints about CPAP or not able to tolerate the therapy, it's important for those patients to have alternative options of treatment for their sleep breathing disorder. BiLevel is the main alternative choice, offering patients decreased work of breathing with the changes in the pressures and the coupled breathing patterns A sleep technician should be looking for clues that the patient is not tolerating their CPAP therapy. These patients may not come right out and say that they don't tolerate the pressures. So digging a little deeper into the patient's reason why they aren't being compliant with their CPAP therapy. They may talk about difficulty falling asleep at night, even with their CPAP, anything up to staying asleep, or they may be moving around a lot in their bed still, and even during the study. When your patient's doing any type of actions that make you wonder, you should ask them if they're having problems, what they think about the pressure, to kind of get them to answer the question for you if they're having problems with it. When their issue that they're having is directly related to the pressure, or you suspect it is, try the patient on BiLevel therapy so you can see if it makes it better for them, if they feel better, and if they like it. Often doing that alone will help the patients relax, they'll calm down, and they may even continue a study where they were just moments ago wanting to leave. Another reason that BiLevel is used is for central sleep apnea. The reason that it's used for central sleep apnea is it's proven effective for treating patients due to the mechanics of the ventilation support offered with BiLevel. The ventilation support is a combination of the pressure difference, which we said earlier was the pressure range between 4 to 10. So there's a water pressure difference from the IPAP and EPAP, and the rate of change between the two pressures will allow for gas exchange of CO2 and O2 within the lungs. So central sleep apnea can be caused by CPAP use alone. It is caused by other reasons as well, but what happens with CPAP is it will increase the volume of the breath the patient takes in, and the increased constant volume of air causes the patient to stop breathing and have central apnea due to the lower CO2 levels that occur as a result. Other reasons that central sleep apnea can happen because your brain doesn't send the proper signals to the muscles to allow you to control your breathing. Central sleep apnea may occur as a result of other conditions like heart failure, stroke, and even high altitude living. Our BiLevel modes, we have a spontaneous mode. We also have a timed mode, spontaneous timed as well. Spontaneous BiLevel is when the patient's breathing to initiate the changes from the IPAP to EPAP. So spontaneous mode senses the patient and is able to accommodate on the patient's terms. Timed mode does not sense the patient, and it's delivered at a set timed interval where it switches from IPAP to EPAP. It can be a more uncomfortable mode for patients, and everything is set and limiting that they should control. This mode really isn't used alone that much. The third option, and the main option, is spontaneous timed BiLevel. It is essentially the best of both worlds. It allows for the assistance of spontaneous breathing and the security of backup respiratory rate with the time setting. So it is preferred because the patient is allowed to control their own breathing, but they also have the ability to have the BiLevel take over for the patient to maintain regularity in breathing. In this mode, a technician will allow the patient to be more comfortable and also help with compliance as well. To give you an idea of when to use which mode, there are several different reasons why. You have your indications for spontaneous therapy. These are CPAP intolerance or continued obstructive events at higher pressures, hypoventilation with SpO2 less than 90% for COPD. Indications for spontaneous timed therapy could be things such as neuromuscular restrictive disorders, COPD, obesity, hyperventilation, central sleep apnea, complex sleep apnea. The reason that you notice the difference in the types of indications of the therapy is with the time therapy, we all end up needing to have that regularity because there is a lack of communication between the muscles and the brain. For just spontaneous therapy, there is that communication there between the muscles and the brain, so it is not neurological in origin. So moving on to the titration of BiLevel. The titration of BiLevel is a process of gradual adjustment in the strength of pressures until the optimal pressure levels attained. Essentially, you may be increasing and decreasing the pressures depending on what is happening. IPAP and EVAP pressures are titrated separately during therapeutic study, and they cannot be the same pressures. With the goal of eliminating an event, you increase your IPAP or EVAP depending on the type of event by at least 1 centimeter every 5 minutes. You increase your EPAP for apnea events. EPAP performs the same duties as CPAP in acting as a stent to hold the airway open and prevent the airway instability. You increase IPAP for hypopnea, snoring, arousal, oxygenation events, and issues. Looking at a full night BiLevel titration, this is when we have our patients come in for their sleep study and they're starting out on BiLevel therapy. According to the ASM guidelines for a PAP titration, I will be referring to children and adults. The recommended starting IPAP and EPAP settings should be 8/4 centimeters of water pressure. The maximum IPAP for an adult should be 30 centimeters of water pressure. The maximum IPAP for pediatrics will be 15 centimeters of water pressure. I will be referring to pediatrics as less than 12 and adults are greater than 12 years old. So we start out with our recommended starting pressure of 8/4 centimeters of water pressure. And then what you do is when you have your events, you increase your PAP settings for by 1 or more for pediatrics or 2 or more for adults for obstructive apnea. We want to do at least every 5 minutes, no sooner than every 5 minutes for any change in titration. And we need to make sure that we're keeping our minimum difference between IPAP and EPAP of 4 centimeters of water pressure. So that means that whenever we're seeing our obstructive apnea events or our apnea events, that we are increasing both of them when required to. You can increase IPAP for several different reasons. I like to think of it as you increase EPAP for your lung and neck issues, your central and your body events that are happening with your apneas, and your IPAP are for your upper airway issues that are occurring, such as your hypopneas, your ureas, snoring, and oxygenation issues. So 1 hypopnea for pediatric patients or 3 hypopneas for adults are reasons for increasing by at least 1 centimeter water pressure. 3 ureas for pediatric patients or at least 5 ureas for adults should be considered to be increased after 5 minutes. As well as snoring, loud, unambiguous snoring for more than 1 minute for children, pediatrics, and for more than 1 minute for adults should also be considered for increasing by 1 centimeter water pressure. So when we have respiratory events have been all eliminated, we then look at our oxygen saturation. If our oxygen saturation is less than 90%, then we should consider increasing the IPAP by 1 centimeter water pressure by every 5 minutes to see if this will help us change that problem. We look at split night titration. We still, again, start out with the general consensus of the 4 centimeters of water pressure for our EPAP, and our IPAP should be between 4 to 10 higher than our EPAP. Another good idea is to start our EPAP level where our last observed apneas were eliminated on CPAP. Keep in mind that you need to use your judgment when setting your EPAP pressure. For example, a patient that was on a CPAP of 13 centimeters of water pressure and they're being changed over to BiLevel, the started settings could be 17 over 13 with no problem. But if your patient was on a CPAP of 19 and you felt that that was when their events were eliminated, changing them over to BiLevel, you would want to reduce your EPAP settings to allow room to titrate the patient through BiLevel. You wouldn't need to have a drastic drop for your EPAP, but it should be a reasonable drop in pressure to allow you room to titrate the patient. For obstructive apneas, the guidelines continue on the same after you get the patient set up. We still increase our EPAP for our obstructive apneas. We increase by 1 centimeter at least every 5 minutes, no sooner. And we want to make sure that we're paying attention to our minimum difference. For our IPAP, we are still using IPAP for our hypopneas, rear snoring, and oxygenation issues. We still consider every 5 minutes. If they're having significant amount of events, such as 2 for adults, for our apneas, 3 hypopneas for adults, 5 reros, 3 minutes of snorting, and oxygen saturation below 90% is when we consider changing our EPAP and IPAP settings respectively. We looked at our other steps that we need to consider with our BiLevel titration is guidelines through the ASM on expiration of IPAP. Some of you may already be doing these steps, and others may not understand why someone would increase their pressure to see, with the common reason being to see if this is giving a better study. The ASM guidelines say that PAP titrations, you can increase them for the expiration, your IPAP, you can increase it for the expiration to see if the settings are better or worse. But what they are suggesting is that the pressure should not be increased more than 5 centimeters during this expiration period. Reducing pressures. When a patient awakens and complains that the pressure is too high, the pressure should be restarted at a lower IPAP pressure, chosen as one that the patient reports is comfortable enough to allow them to return to sleep. So you could also do the same for the IPAP as the EPAP to maintain your minimum differences. The use of spontaneous time mode and a backup rate. A decrease in IPAP or settings in BiLevel and spontaneous time mode with a backup rate may be helpful if the treatment of central apneas, if you're suspecting complex sleep apnea, if you're seeing those type of events during your study, you may want to consider adding in a backup rate to compensate for the patient's issues. Down titration is when you're decreasing your pressures down for a number of reasons to essentially restart your titration. It is not required, but it's considered an option. So if you feel that something just isn't right and you want to go back down on your pressures, that is within your reason to go ahead and do that through the ASM guidelines. So to simplify all the titrations that I just went over, okay. Titration simplified is EPAP is only increased if there's at least 2 obstructive events. IPAP should be increased for at least 3 hypopnea, 5 RERAs, and at your discretion for 3 minutes or more of snoring and oxygenation issues. Keep in mind this is within a 5-minute window. You wouldn't go any faster than 5 minutes for your severe patients. And you would want to take into account allowing patients time to get used to the setting. Myself, I usually titrate patients about every 15 when they're more severe so I can maintain control of the patient's breathing issues. When we talk about obtaining optimal pressure, the main thing is the goal of the titration. Every titration has the same goal. We want to have a RDI less than 5, a oxygen saturation greater than 90%, arousals and RERAs less than 5 per hour, and elimination of snoring. Other acceptable goals along with these main 4 are the elimination of obstructive events, mask leak occurring within acceptable parameters at the given pressures as well. So how are we maintaining adequacy of titrations? Titrations are graded essentially with through the ASM by the following parameters. For an optimal titration, your RDI is going to be less than 5, for a desaturation of at least 15 minutes, duration of at least 15 minutes, including measurements during uninterrupted REM sleep. A good titration would be an RDI of 10 or less, or by 50% of the baseline RDI is less than 15, including measurements during uninterrupted REM sleep. An adequate titration would be the RDI has not been reduced to 10 or less, but has been reduced by 75% from the baseline, or titration meets optimal or good criteria except during supine REM sleep. When titration is defined as unacceptable is when it doesn't meet any of the above grades. If the initial titration doesn't achieve a grade of optimal or good, a second PAP titration should be considered for that patient. If the initial titration is a split night PSG setting, a second PAP titration should be considered if it fails to meet the ASM criteria, such as the 3 hours of titration time. A optimal titration for PAP therapy for OSA has been defined with an RDI of less than 5 for at least 15 minutes to include uninterrupted REM sleep. So ideally, when we are titrating our patients, we want to keep in mind that we want to be able to get them in REM, which isn't always possible, but we also want to take care of our respiratory events. So going back to our goals, when we take care of our respiratory events, that's the same as taking care of our RDI down to less than 5, which puts them at a normal event category. So when we have our severe patients, when they come out as being adequate, should you be hard on yourself? No. because that patient has been reduced, and something is better than nothing. And some people are, each patient is going to be different as far as their titrations and where you can get them within a 1-night period, which is why patients will come back every so often to have their titrations adjusted. Each technician has a significant role with compliance. As a technician, you are there for the patient. The patient is most likely new to this process, and how they're treated and their experience with the whole titration process will deeply impact them and their decision on what they think about PAP therapy. As an educator, there's a need to ensure that your patients are educated on the entire process. You very well could be the first and the last person to educate the patient on their therapy. So letting them know each step that they're going to go through, from, if you happen to be scheduled in the patient, so you talk to them about when they come in, make sure they know what to expect then, and then continue that momentum as they go through the entire process of evaluating their sleep disorders. All patients with OSA, or who are potential candidates for OSA and PAP titration, should be given adequate PAP therapy education. Should include some type of hands-on demonstration, showing them the mask, fitting them with the mask, letting them try them on and figure out what they like, and so they could understand what you have been talking to them about. An acclimation before the titration is started is best. Letting the patients wear the CPAP mask or your BiPAP mask, I would say. So wearing their mask for the therapy, and getting used to the pressures and how the breathing will be is ideal before you titrate a patient. As an encourager, you are there for the patients from the beginning with their education and on the entire process, providing them encouragement, letting them know that they are not alone. It's actually a very empowering tool. You can use this time to talk to the patients about compliance, provide support for their issues, recommend support groups to the patients that are in your local area, and let them know if they're complaining about certain issues that they're not alone, that it's very common, and it's kind of expected for patients to complain about these issues. It allows them to be comfortable with what's going on and trying new things, as well as their entire situation. As an evaluator, you are able to talk through and fix the issues before the study is started. We're going through the whole mass trial period, and if they find out that they don't like to have a nasal closed mask because the pressure, the way it feels, you're able to evaluate if this is the best mask for them, even if they feel better. And as well as during the study, you develop your strong clinical background on your goals and your habits of therapy. You're responsible for deciding in the end what mask is right for the patient. Look at the pressure settings, and realizing when that you need to change over from CPAP to BiLevel. All helps with compliance to getting the patient to their optimal goal. You as a technician, you have the power to influence patients for or against PAP therapy, and we really need to keep that in mind towards how we talk about something, or our body language when we're in the room may turn them off to something that they need. So really it is all our responsibility to ensure that we're all doing the right thing for our patients, and doing the best that we can to help them through this process and to make sure that they are well informed about their issues and their therapy options. There's several things to remember. BiLevel is IPAP and EPAP. And our IPAP is always greater than our EPAP. I realize this is probably back to some of the basics. But there is a difference of at least 4 centimeters of water pressure to 10 centimeters of water pressure between our IPAP and our EPAP settings. And patients, BiLevel is a ventilating mode, and it is for patients who are intolerant of CPAP or with central sleep apnea mainly. Things to remember about our titrations is that we want to move by no quicker than 5 minutes on our pressure settings, and then we move our apnea. We move our EPAP for apnea events. We increase our IPAP for our upper airway events, such as our hypopneas, our RERAs, for snoring and oxygen issues. We also want to remember that our goals of titration are to have an RDI of than 5, and we also want to look for titrating the patient when they are in REM. If the initial titration does not achieve an optimal or a good setting, then those patients should really be coming back for an additional study. I know that you are to be there for the patient. You're the educator, the encourager, the evaluator through the whole process, and just letting them know that they're not alone will help them along with their compliance. Quality care is provided by competent and well-trained professionals. BiLevel works great and is a great tool for increasing patient compliance and comfort, but just giving a patient BiLevel and not explaining, not educating them on their situation will not increase any type of compliance or comfort, especially if they're not using it. We want to make sure that we listen to our patient complaints. If they are complaining about our CPAP pressures, then we really need to, instead of pacifying the situation, try them out on different settings, try them out on BiLevel to make sure that that you find something that is mutually beneficial for yourself as well as the patient, with them staying through your sleep study as you're titrating them, and also continuing therapy on their own when they're at home. We also want to remember that the spontaneous high mode is going to be our go-to mode for patient titrations. It allows us to add in our backup rate when we need to, as well as letting the patient be comfortable with the changing from IPAP to EPAP pressures. I'd like to thank you for your time and listening to this webinar broadcast. All right, so we'll go ahead at this time and like to open it up for questions, question and answer portions.